Hi, everyone. I'm Farhan. I'm one of the ICU attendings. Welcome to Grand Rounds. I get the pleasure to introduce to you today Vinay Nadkarni. And for those of you that don't know who Vinay is a professor and an endowed chair in critical care medicine and anesthesiology at the Children's Hospital of Philadelphia and the University of Pennsylvania Perelman School of Medicine. He's an incredible individual that we're lucky to have here. Vinay is the founding director of their Center for Simulation, Education, and Innovation at the Children's Hospital of Philadelphia. If I told you guys that he has 85 publications, 3 in the New England Journal, 2 as senior author, 2 in JAMA, 3 in JAMA Pediatrics, which is the highest ranked journal in pediatrics, 5 in Circulation, which has an impact factor of 20, and about 18 in the journal Resuscitation, which is a top journal in emergency medicine. I think most of us as researchers would be pretty impressed. If I told you that that's what he's published since January 1st, 2017, I think that's the shock that most people would have. For the junior people in the audience, Vinay has 500 publications and book chapters. That's almost unheard of. That's more than most departments, most divisions that I can think of, and probably more than most departments of pediatrics. But I'll tell you that Vinay's strength is actually, in my view, it's not as a researcher. He's an incredible researcher, but he's actually a better leader, innovator, implementer, and educator. He's been the only pediatrician to lead the International Liaison Committee on Resuscitation as a co-chair. He's led the American Heart Association Emergency Cardiovascular Care Committee. He's set up national networks, Get With the Guidelines Resuscitation, which covers 10% of the hospitals in the United States that provide data on their CPR outcomes. He's set up educational groups that are simulation groups that are over 100 included in those groups. It's no wonder that he's actually received multiple national and international awards. Just his national awards is a page on his CV. That's his national award. So the key ones that he has, he was voted or elected as a giant in resuscitation from the International Liaison Committee on Resuscitation. 5 people in the world get that every 5 years, and he's only the 3rd pediatrician to actually receive that. He's got a Lifetime Achievement Award from the American Heart Association in Emergency Cardiovascular Care and the American Academy of Pediatrics in critical care medicine Lifetime Achievement. I think I've just embarrassed him entirely. If you know Vinay, that probably the most incredible thing about him is when you meet him, you don't capture any of that. He's probably the most humble, incredible person that we get the opportunity to work with in resuscitation. He's mentored over 100 people. He is giving, and even as an example of that, and I'm sorry to call him out here on this one, but you get an honorarium for presenting at presentations like this. Vinay actually donated his honorarium for our PICU fellows so that they can use that money for their education. That's the type of person he is, and we're really fortunate to have him. So welcome Vinay, and look forward to this presentation.
Well, thanks, Farhan, and good morning. And none of those things happen because of an individual. It's really always a team effort, and the team that I get to work with is really the major part of it. This morning, I have no relevant financial conflicts of interest. I do have some research grants in the area of some of the things we're going to be talking about early warning scores, about therapeutic hypothermia, some of the tools. None of the photos and none of the things that will be on the slides are intended to endorse any product or any medication, et cetera. And what I hope to do this morning is just to walk through a little bit of the past, the present, and the future. What can we learn? What were some of the seminal observations and discoveries that sort of formulated resuscitation science? How are we implementing them today, and is it making a difference? And then what's coming in the future? How can we prepare better for whatever care environment we work in, whether it's an intensive care unit on the ward, in a clinic, or in a rural center, or at home? How can we do a better job, and what's coming in the future to sort of help us? If you think with me for a moment how we practice, how do we go from facts from anecdotes to studies to evidence to guidelines to practice to practicing well that actually saves lives? it's a complicated process. And most of us are very much captured by the stories that we hear and read about, and those that are around us, our family members and friends. When something happens, we really get motivated to do something different. So it's probably no different in resuscitation, but just pause for a moment and think about how this child on the screen would be resuscitated in 1960, before there was really any CPR, closed chest cardiac compressions, that was really discovered or disseminated. In 1988, when the first Pediatric Advanced Life Support course was formed. In 2000, when the first AEDs were being placed, automated external defibrillators were being placed in the community. In 2010, when the evolution of in-hospital resuscitation started to include eCPR and ECMO. I know there's some ECMO folks here. And what about in 2020? How are we changing so that the few things we know that work in resuscitation actually get to the patient? Almost all of what I'm going to talk about today is summarized for you, and the evidence evaluation for the evidence-based practice is present on ilcor.org. So you can look at each of the topics, each of the controversies, each of the interventions individually, and there's a list there of the evidence evaluation that led to their recommendation or non-recommendation. And ILCOR, this international committee of the 7 resuscitation councils around the world, does now continuous systematic reviews on topics as they emerge. Should we be using epinephrine? Should we be using laryngeal mask airways or endotracheal intubation? Should we be intubating at all? As those controversies have a publication in the New England Journal or JAMA, et cetera, they start to evaluate and put into the evidence base, should we make this a consensus statement? Should it become part of our guidelines? And should we do the training and implementation to make it real? Let's think back for a few years. What are the key things that kind of led to changes in our field? Here's a photo of the article that came out in 1946 when the Blalock-Taussig shunt essentially became possible because Vivian Thomas, a non-physician, was able to craft a small tool, a vascular clamp, that allowed sort of a new way of treating children, blue babies. Here's John at Thomas Jefferson University in Philadelphia, the first ECMO pump, the open heart surgery, 1951. And look how large it is and cumbersome. And here's Paul Zoll's first pacemaker. This is the pacemaker that now is like miniaturized and people wear, right here. It was a huge machine that you had to walk around on a cart. So these kinds of things were things that people knew how to put together, they observed and they made, but they weren't practical, they weren't implementable. But those pioneers kind of allowed us to make a quantum leap. Let's think about for resuscitation. And for resuscitation, it was a little different. I'm going to show you a little bit of the past and the history because I think it's important. The things they knew then are still important now. If we think about resuscitation in the context of all the other pediatric diseases that we teach, we have, between the 50s and 2018, made amazing improvements. If you think about leukemia, septic shock, HIV, congenital heart disease, diaphragmatic hernia, these were universally fatal in 1950 and 60. And over time, there were either they were sort of observations like steroids work for leukemia. That surreptitious kind of treatment that somebody noticed made a difference. And then with the Children's Oncology Group, those incremental changes in the medications and treatments, by collaborating together, were able to make improvements that took a 5% survival to a less than 5% mortality over those 50 years. If you think about HIV, it's the same way. If you think about the intraosseous needle and fluids, it's the same for septic shock. But for cardiac arrest, it's been a much slower and more gradual improvement, incremental changes, and then only in the last 5 years have we started to see a doubling of survival from pediatric cardiac arrest, not because of new discoveries, but because of new ways of implementing the few things we know and getting people to do them well and to do them often. The enormity of the problem is huge. If we think about adults, more than 1,000 a day, 2 full 747 jets loaded with people crashing and burning and dying each day is the North American burden of cardiac arrest. In children, it's like 2 school buses, 50 children a day who die from cardiac arrest. But if we think about the positive, because the adults are older, 50, 60, 70 years old, because they have underlying conditions, the number of quality of life years saved per day is about 10,000. Because children are generally younger, healthier, and have more and full lives to live after we resuscitate them, almost a third, as many as adults, quality of life years could be saved if we really did a good job and were able to implement what we know works. Unfortunately, what we know gets lost in translation. What we know and is published today that gets transferred into guidelines and medical standards gets taught, learned, and remembered from our courses and training. And then when we observe what we do, only about 3 to 27% survival is sort of reported. And that loss in translation is trackable. As we sort of employ the formula for survival, do rigorous evidence evaluation, deliberate practice, frequent refreshers, audit, review, debrief, and then implement, we can actually improve that translation to now reporting 10 to 60% survival. About 75% of survivals, you might be surprised to know, have good neurologic outcome. Go back to their previous level of function. So that it is worthwhile, it's important to do it. And the Institute of Medicine, now the National Academy of Medicine, collected and put out a report in 2015 that really identified that in-hospital cardiac arrest and resuscitation is completely different. The system of care is completely different from the out-of-hospital system of care. And in fact, pediatrics is yet again different because most of our arrests are respiratory in nature, oftentimes in relatively healthy children, particularly in the out-of-hospital, with either toxin or trauma associated. And so we can adapt the system of care for children, but we have to think differently in and out of hospital. So let's go back and see where some of this came from. The seminal study for cardiac arrest in 1960 was published on 20 patients. They, Cohenhoven, Knickerbocker, and Jude, a surgeon, an engineer, and their research lab, had been working in the lab because workers who were putting up electrical lines were getting electrocuted, and they needed to find a way to shock their heart. When they fibrillated, they needed to find a way to shock their hearts back to life. And what they noticed in the dog lab, when they put the paddles on the chest of the dog and they had them instrumented under anesthesia, was that when they squeezed hard on the chest to make contact with the defibrillation, they saw a blip on the arterial tracing. And when they released and pushed and got contact, they could create an arterial blood pressure just by pushing and releasing in a closed chest the first time. That observation led them to do experiments in the lab and subsequently try it out in humans who were getting anesthetic overdoses with ether and dying in the operating room. And they noticed when they employed this, they had a really good survival. They went from 0 out of 20 survivors to 14 out of 20 long survivors, 20 out of 20 immediate survivors. So closed chest cardiac compression worked. But let's hear them tell you a little bit about this. Guy Knickerbocker lives in Pennsylvania, not too far away from us, and we went down into his basement, and he had these old films that were converted over, and he let us use this.
Chest massage that we will demonstrate.
This is
You may wonder why
This is Cohenhoven.
how we got into this development. Briefly, in 1957, the closed chest
Guy Knickerbocker is the engineer who's kind of slinking over there on the side.
functioned successfully and defibrillated hearts. But if the heart was going to resume autogenous beats,
And that's the original lab in the basement of Johns Hopkins Hospital where these doctors worked. Now, the CPR that they performed was actually quite good. And here's Guy Knickerbocker with his watch on and no gloves, pushing on the dog's chest. And they're using an oscilloscope to measure the blood pressures and the heart rates, and they actually were monitoring the cerebral blood pressure as well through the carotid artery. But you can see that the quality of CPR they're delivering was quite good. And what they discovered was that when they got the diastolic blood pressure above 30, their outcomes of the dogs were really good. What's really incredible, when we go back to the 1960 publication, and this is actually in the 1961 subsequent publication where they published this, we've now rediscovered when we do surveys and we download the bedside monitors of our children, real children, that a diastolic blood pressure of greater than 30 is associated with better survival and neurologic recovery. In children over 1 and under 1, that diastolic blood pressure cutoff is 25. That was just recently published but we knew it back in 1960, but it's only now that we're really rediscovering it and using it. But what about airway and breathing? Peter Safar, who was the giant of resuscitation, created a symposium on emergency medicine very similar to this. And he brought together some experts, and they made recommendations which are very similar to today about pushing hard, pushing fast, minimizing interruptions. And here's Peter Safar. He's the one who will be doing the rescue breathing, and I do have to warn you that at this time, this was before IRBs, the people who are anesthetized and paralyzed are medical students or workers in the labs, volunteers, voluntold volunteers, who volunteered to see if rescue breathing would actually work. And so let's just look at a little of this.
The inflations
Peter
of 1,000
Safar
to 2,000 cc's of air are
breathing
possible
actually for his
the following
chief.
reasons. First, the operator produces an open air passage by supporting head and jaw.
Now he's going to
He
obstruct
can
the airway.
determine the adequacy of ventilation by
He's
watching
going to demonstrate
the
that
chest
there's no
movement,
air going into the
by
chest.
feeling the inflation, and by hearing exhalation. Second,
Now he's going to open the
inflation
airway.
pressures are adequate and can be adapted
And for the
to
first time was
distances
able to sort
encountered.
of demonstrate that there's a
The
technique,
oximeter attached to
exhaled
his ear measures the relative
gas,
arterial oxygen
17%,
saturation,
that would
which was
sustain it.
97% when he was
This is
conscious
now a
and
medical
breathing
student
naturally.
who's doing rescue breathing for 30
This
minutes
medical student
for this
performed mouth-to-mouth
paralyzed
breathing for
anesthetized
30
volunteer,
minutes without interruption.
except when
As you
she's
can
asked
see
to
in the
interrupt.
corner, the oxygen saturation is still 97%.
This is an ear oximeter, an
Now she
early
stops
precursor of the
ventilation
pulse
in order to
oximeter.
demonstrate how rapidly the oxygen saturation drops during apnea. Within
worry, it
30
comes out
seconds,
okay.
It begins to drop. Usually, there is not time to get resuscitation equipment.
Now watch what happens in 6 breaths. Exhaled air, 17% oxygen.
Inflation of the lung should be started immediately. Now start. 1, 2, 3, 4, 5, 6.
So this was a very, remember I said that people learn by anecdotes? Like you could publish a whole bunch of stuff, but what they did was they took this video and they went around to medical societies around the country and they showed this to demonstrate that rescue breathing, which was not thought to work at the time, really could work. And it was very convincing, and it really brought rescue breathing into it, an observation, because before that it was all, the old physical methods of drowning and CPR. And then they did one very important thing. They didn't just stop with, yes, it works. They were figuring out how they would train it. So they went to a doll maker in Norway named Asmund Lerdahl. He made little toy dolls for children and storybooks. And his son, Tor Lerdahl, had fallen into the ocean, and he had to pull him out, and he had heard about rescue breathing, and he gave him a breath of life, and it worked. And so he became very interested and said, what can I do to actually teach people to do this? So he started to make Resuscitation dolls, which, with Peter Safar and others' help, they were able to mold. So if you look at Peter Safar getting ready to rescue breathe for this real human anesthetized paralyzed patient, and here's Asmund Lerdahl, breathing for Resuscitation. He created it so that the technique could be taught. And that was really a breakthrough that we're still learning from, how to make tools that will help people learn CPR in a very practical, cheap manner when it's a rare event. But they had another problem. There were no ambulance systems, there's no emergency systems, and I know there's some emergency medicine folks here. They couldn't get anybody to go out and retrieve people who had had an arrest at home. And they didn't have any vehicles that would work for that. So Peter Saffer, who was in Pittsburgh and lived across from a morgue, where he saw how they transported coffins to funerals. And so he basically took the hearses that were long enough to fit a person lying down, dead, and he got the workers, these are called the Freedom Fighters, this group, this motley crew of people, and you can see they're very culturally diverse, because they were essentially the janitors and workers in his hospital who said they were willing to go out and take somebody who had just died with CPR in progress, get into the hearse and drive them to the hospital. And so he converted the hearse that were sitting right outside the hospital in this morgue into the first ambulance system in the United States. And in that way, he got a vehicle to get people who had died on the street into the home, into the system. And so, did he stop there? No. He then said, well, we have a system in Pittsburgh that can actually do that. And they were doing the same thing in Edinburgh and some other European cities. He said, but nobody knows about it. And at that time, TV wasn't even universally available, but people would go to movie theaters and they would see shorts before the movies about war, about different topics that were supposed to educate them. So they made a video.
But many victims of suffocation need not die, because they can be saved by rescue breathing. This tragedy should not have happened. Any one of these neighbors could have saved the life of this victim of suffocation. How about you? Suppose someone in your family suffocated, became unconscious, and stopped breathing. What would you do? Could you bring her back to life? You. I mean you. Who? Me?
So it was kind of a fun way, but it was exposing the public to something they could learn and do. And now they had a Resuscitation where they could actually go to a place and learn and then capture those stories. And so this became a very important tool. One other thing that was happening around this same time that some of you, Ron, you might remember this.
It was an uphill battle to restore belief
This
in the
was
mouth-to-mouth
the
method
polio
in the middle
epidemics
of a polio
were
epidemic.
working.
One day,
And
a very young
ventilators,
Dr.
these
was
are
on the
negative
wards at
pressure
University
ventilators.
Hospital in Minnesota.
Being widely employed.
Came
This, I think, was in
to
LA,
us
Ron.
Pushing this new admission.
But this is Dr. Elam.
about probably
And he's telling a
14,
story, an
15
anecdote
year
again.
old adolescent kid who was as blue can be. And I interrupted the whole thing, wiped the mucus off his chin. I thought, but I couldn't do it. I couldn't get all of it off. So I used a sheet and my hand and covered his mouth, tilted his head back, took a big breath, and inflated his lung. In 3 breaths, he was pink. I was then advised by the smart intern that I would get polio. I guess I was just cocky, I don't know. There's also the fact that here's a human being about to die. And I knew the manual methods wouldn't work either. I didn't have any oxygen. Yes, I did, right there.
A very compelling story that moved a lot of people to just try it. But about that time, about the time when I was training and doing my residency and internship, reports were starting to come out about what the survival for children in hospital of cardiac arrest were. 9% survived to discharge. 0 of 21 survived after more than 2 doses of epinephrine at my hospital, Children's Hospital of Philadelphia. Similarly, at Children's National Medical Center, a very similar survival to hospital discharge, with 0 of 31 surviving if more than 2 doses of epinephrine or more than 10 minutes of CPR was required. And so the outcomes were really quite dismal, and CPR was kind of a last rite of death. You know, it was what you did before a patient died. But then, as we emerged from that era, we started to realize that CPR wasn't all the same, that shockable rhythms needed defibrillation, that there's a hemodynamic phase where just creating excellent perfusion and oxygenation will make a real difference, and then a metabolic phase where maybe more is needed, maybe ECMO or other cocktails to try to return. As we looked at the studies that were coming out, we knew that if there was no CPR and delayed defibrillation for a patient who had sudden cardiac arrest, there was really very little hope of survival, but that if early effective CPR could be provided, we could double to quadruple the survival even in the out-of-hospital setting. If we then added CPR and defibrillation early and effective together and got them to hospital, it would be 20%. And in systems that were doing CPR, defibrillation, advanced cardiac life support en route, and then continued post-resuscitative care, almost 30 to 60% survival, about 75% intact neurologic outcome. So that it was possible in systems that had got it together to make a real difference. And so the concept of a system of care emerged, with links only being as strong as the weakest link. And the concept that we have to measure what we do along the way became very apparent, but was difficult. We recognized there were different phases of cardiac arrest. In pediatrics, we certainly recognize that the pre-arrest phase, where we can protect the child and respond before they arrest, is the most important thing. That's what we do in pediatrics: prevent, recognize, and treat. During cardiac arrest in the no-flow time, we have to recognize if it's a shockable rhythm and promptly start CPR. And then in the low-flow phase during CPR, pushing hard and fast, minimizing interruptions, not overventilating, and potentially looking for reversible causes and sustaining or supporting the child with ECMO, etc., until we can get that fix in place is important. And very important in the post-resuscitative phase, not dropping our guard, using targeted temperature management, blood pressure, oxygen, ventilation, treating seizures, and considering other interventions that may reverse the etiology and the cause. Most importantly, we've made advancements in early recognition and response by either electronic or early warning scores or vigilant providers, recognizing the signs and symptoms that are pre-arrest and intervening. In fact, in Canada, the EPOC study, Ron recently completed, suggests that early warning scores, even in community hospitals, can trigger a move to an intensive care setting where providers and the patients are in an environment where they're being cared for that potential emergency. Although there wasn't significant improvement in mortality was low, fortunately, it suggests that perhaps there are opportunities to recognize these impending problems earlier. But one controversy that exists is in the out-of-hospital setting. Can rescuers or dispatchers recognize when rescue breaths are needed? The adults, who are very focused on cardiac rhythms and sudden cardiac collapse, getting a defibrillator to the patient who has ventricular fibrillation, are focused on providing hands-only chest compressions, getting an AED or defibrillator to the bedside, and transporting the patient to evaluate whether they have a blocked coronary. That philosophy is important for children, getting continuous chest compressions and blood flow going, but because so many of our arrests are respiratory in origin, it's very important that rescue breathing is not ignored. And so what's been demonstrated in the registries in Japan, and again in the CARES registry in North America, is that rescue breathing with chest compressions is associated with better outcome in children compared to no chest compressions, for sure, or chest compressions alone. And so we continue to feel that rescue breathing is important to teach to rescue children. Not overventilation, but some ventilation. In adults, the same differentiation, just the chest compressions and early defibrillation seems to be adequate. And so there's a lot of controversy over what dispatchers should be saying. Now, we spend a lot of time in our ACLS and PALS courses talking about medications, what dose of epinephrine, amiodarone, blah, blah, blah. But the truth of the matter is that there really is no definitive trial that demonstrates that even epinephrine is important in cardiac arrest. We've all had anecdotes, we've all experienced that it does increase the blood pressure, in many cases the blood flow, and the return of spontaneous circulation. But there's no association with even epinephrine and long-term neurologic outcome. We do know that if we're giving epinephrine, and we're giving it for a purpose because we're watching a blood pressure in the ICU, that we can improve outcomes by giving epinephrine early. But too much epinephrine may be detrimental for the brain, heart, and lungs in the long run. And so the balance of what medications to use is not well known. And even in adults, you may be aware of the recent paramedic trial, was suggested that placebo versus epinephrine for adults in out-of-hospital cardiac arrest had no beneficial effect. Placebo versus epinephrine. And so suggesting that the emphasis on drugs is probably overemphasized, and the basics of good quality CPR and, if appropriate, rescue breathing have to be emphasized rather than drugs. Now, what other lessons have we learned? This is a photo from the front page, the cover page of Sports Illustrated magazine, where the nation's #1 college basketball player was known to have some hypertrophic cardiomyopathy. And thus, he was always supposed to have a physician and one of the very early automated external defibrillators in case he had a sudden arrhythmic event at the courtside. So he did. But he unfortunately collapsed during a game with a sudden ventricular fibrillation. And the doctor and the medic who were at the side, because this was a relatively early automated external defibrillator, they were there, but they hadn't really been trained that well on it. And they really didn't want to open it up in front of the crowd and sort of fiddle with not being sure where to put the pads and how to turn it on. So they took him off the court in a stretcher, no CPR in progress, and it was about 10 minutes until they could actually get his shirt off, get the AED on, get it on, and by that time it was too late. So this automated external defibrillator being carried in the right hand, the technology to cure and save this adolescent's life, and carrying him off with no CPR in progress in the left hand was the gap between what could have been done and what was actually done. And it really brings home to me that we can have all the technology in the world, but if we don't either train and know how to use it, or if we don't apply what's available, the simple things, our own two hands, then we're not going to make the difference that we want to make in the world. Oxygen is the same story, very controversial. Here's an oxygen bar in Colorado. How much oxygen is enough? Should we be giving 100% oxygen? In neonatology, we no longer initially resuscitate with 100% oxygen because the first gasp is delayed, because there are secondary injuries from superoxide in the brain, etc. But we continue to do that in pediatrics and adults. And we know that from adult studies that in the post-resuscitative phase, hyperoxia and hypoxia are both harmful compared to normoxia. And so we are looking and trying to discover, is there a threshold above which or below which oxygen therapy is harmful or helpful? And right now, the recommendation of 94 to 98% saturation is because we're worried that too much oxygen may be harmful. Dr. Berg and Kern and a number of people in the PIG lab were able to demonstrate that in the post-resuscitative phase, there's a lot of myocardial dysfunction, even in previously healthy hearts. They did echocardiograms, they did radiographs, they did biomarkers, And pretty reliably, between 6 and 24 hours after resuscitation from a cardiac arrest, there's a lot of myocardial dysfunction on both the left and right side, which can be ameliorated with vasoactive support. So the post-resuscitative phase is really important. A lot of the current controversy revolves around whether we should be using therapeutic hypothermia, targeted temperature management, or not. The idea in the lab works quite well is that slowing down the metabolism, decreasing the inflammatory effect, and preserving function, therapeutic hypothermia 32 to 34 degrees does a really good job when instituted before or immediately after an insult. But those findings have not persisted in human studies, particularly when the hypothermia is instituted 6 or more hours after the event. And so just like stroke care, just like myocardial infarction, time is brain, probably the ability to get the therapeutic intervention has not been effective as yet. And when tried in the out-of-hospital setting with cold IV fluid boluses, actually the distension of the right atrium and sort of the effects on the heart of a sudden cold IV fluid bolus have not been found to be beneficial. And so what is beneficial is active cooling to at least a normothermic temperature, not allowing the patients to get warm or hot. And so these gentlemen, Frank Moeller and Mike Dean, who were the PIs to complete the therapeutic hypothermia after out-of-hospital cardiac arrest, and then a second cohort in hospital cardiac arrest, found no significant differences between a 36.8 target temperature and a 33 target temperature in a tightly controlled trial across 36 centers across the world. The problem with interpreting this and applying it to our patients today is the criteria for getting into the trial were that you had to be comatose and non-responsive after the cardiac arrest. So it only applies really to those very, very sick and comatose patients after cardiac arrest and doesn't necessarily tell us those mild and moderate injuries, whether therapeutic hypothermia would be helpful. The study was well executed, and the outcomes showed a clinically intriguing difference of 9% of 9% between the in 1 year survival and an 8% improvement in 1 year neurologic function, but these did not achieve statistical significance. So it's considered a negative trial, but still interpreted by some as intriguing and potentially clinically important. We're still left with the controversies and questions about who should or should not be cooled, when to cool them, how deep to cool them, how long to cool them, and how to rewarm them. If you were to look at the bedside of this patient, you'd see a lot of technology and not many people. But you can see how the interplay of these very advanced technology interventions needs to be trained. We can't just expect that the technology that we have will solve our problems. It may go some way towards helping us. This is an example of density spectral array EEG. So Alexis Topchin, Nick Abend, and others, and the folks at Hospital for Sick Kids have discovered that seizures are quite frequent, subclinical seizures are quite frequent after cardiac arrest in the post-cardiac arrest recovery period, but that people have difficulty finding them, identifying them, and treating them. Density spectral array is one technology that may allow the spikes that the neurologist can see to become apparent and sort of recognizable at the bedside. And this is an example where you can see the spikes that you're seeing there are pretty recognizable as abnormalities. And so this is something even I could probably see at the bedside, although I can't interpret a bedside EEG. So the technology is getting better to help bring the intricate background analysis to the bedside in a form that a bedside practitioner can react and treat. So what are the caveats of post-resuscitative care to take home? Targeted temperature management to avoid hyperthermia, blood pressure management to avoid hypotension, control of status epilepticus, which is associated with worse outcome, titration of oxygen, and then control of metabolic factors like glucose. Of course, the ultimate support, like ECMO, is possible for reversible injuries. So where are we now? We have patient, event, and system factors. We have education, techniques, devices, drugs, and systems, all of which are dependent on quality. And our ultimate goal is to get to quality of life and intact neurologic survival. We've talked about some of the physiologic things that need to happen, but how are we going to actually make it happen? Well, we know from observational studies that high-quality CPR, even in our best hospitals, is not common. We know that better CPR is associated with better outcome, and we also know that this can be trained. Point-of-care training can improve CPR quality, and reflective debriefing can improve team performance. And we also know that there are some physiologic targets, if measured, like diastolic blood pressure, end-tidal CO2, and depth, that are actually strongly associated with good outcome. But the question is, can we put it all together, and then can we do it not just in centers like this, but can we do it across the country? Well, look at my hospital. At Children's Hospital of Philadelphia, we have 540 pediatric beds, of which 40% are ICU beds now. We have 5,000 pediatric ICU admissions a year. We have now, this has actually just gone up, 28 attendings, 17 fellows, 120 residents, 350 nurses, blah, blah, blah. There's a lot of people there that form ad hoc teams that respond. In fact, if I was to ask Farhan how many combinations of 5-person resuscitation teams would respond to any one kid in our hospital at any given time, day or night, it's actually more than 1 million ad hoc teams that would have to come together and function well to resuscitate a child. And that's just really hard to train and prepare. So how are we going to do that? Well, what we know is that we have to train the individual to what they need to do. We have to train the team so they perform well, even on an ad hoc basis. And we have to train the system so that things are available to actually support that individual and team. And so by using deliberate practice with real-time feedback, just-in-time training, and performance debriefing, as they do in the military, we have found that we can actually keep the culture of resuscitation current and working. And so by using monitor defibrillators that provide real-time feedback and capture the data that can be displayed in debriefing events, we can start to move the needle. And we can use low-intensity, high-frequency training, performance feedback, and debriefing by pre-identifying the highest risk children for cardiac arrest through our EMR and early warning scores, rolling a cart up to their bedside and training those providers to be prepared for it, and training them frequently in low doses, 2 or 3 minutes a day, so that we essentially have a booster effect for their training, and we can take the variability in their chest compression rate, for instance, in this example, to hone it down to the recommended. And we can apply this and study it, and when we did, we found that our survival from cardiac arrest in our hospital doubled, and our good neurologic outcome went from 29 to 50%. And so it was a real-time example of how taking the evidence, training it better, doing refreshers, debriefing could actually impact patient care and patient outcomes. And so now we've converted this to a scheme where we pre-arrest identify patients, conduct rolling refreshers, during arrest provide real-time feedback and coaching, have a brief real-time reflection after the event, and then prospectively during post-resuscitative care have pre-briefings of the providers, dress rehearsals, to anticipate what's going to happen over the next 8 hours. And then we collect the data, have an environmental debriefing, and we track the patient outcomes that go along with it and report it back in a dashboard. The American Heart Association has now taken and adopted that and is changing the infrastructure from their every 2-year PALS and ACLS courses to a rolling refresher every 3-month resuscitation quality improvement cart that will be in hospitals to enable you to refresh different parts of your training every 3 months to keep current. But these training targets will change. Right now we use rescuer directed metrics. What's the depth, what's the rate, what's the chest compression fraction? But in the future we likely will use blood pressure, end-tidal CO2, and other markers of effectiveness. And in the PIG lab, we can see that there are many different types of problems we have to address. Respiratory arrest, cardiac arrest, arrhythmia, ECMO, so many different problems to address that we probably have to look at the final common denominator, mitochondria, the power pack of the cell, because when it comes down to long-term resuscitation, we're probably going to have to get beyond the mechanics and the physiology grossly and down to the cellular level. To do this, we must form coalitions like Get With The Guidelines, which now is collecting data not from one hospital but from 349 hospitals in the United States using the same tools. Farhan and others have been analyzing this database and have been discovering differences in the quality of CPR and outcomes at night versus day, on weekends and weekdays. And also looking at those interventions that we hold true as gospel. Is tracheal intubation favorable, helpful, or not? And in an associational analysis of the database, tracheal intubation was associated with worse outcomes, not better outcomes, even when accounting for those patients and the duration of CPR. So we have to look at ourselves. We've started to form coalitions of networks of pediatric hospitals that are contributing real-time data from their patients to a central repository so we can start to understand the quality of CPR. And we're starting to send out simulation probes to environments like emergency departments to track them on common cases, sepsis, cardiac arrest, and seizures. And we can start to see differences between what's done in adult hospitals and pediatric hospitals when a child presents to the emergency department, provide them scorecards, and start to evaluate which piece of pediatric preparedness they can link with. But these are just the tip of the iceberg. There are exciting things ahead. As we start to think about how we're going to move from the near future to the far future, we have to think about how we will take the next set of interventions, how we will make it easier to communicate. With social media, how can we adopt some of the principles of coaching from sports, the military, and other industries, how they disseminate their information, how they train, how they learn, and how they do. So with that, I think I'll stop here, Farhan, see if there's some questions from either here or outside, and I thank you for your time and attention.
Thank you very much, Dr. Nadkarni. That was a very interesting talk. Before we open the floor to questions, I just wanted to mention that we were fortunate to have Dr. Nadkarni come present to us as part of the Flanders Visiting Professor for the Steinberg Centre for Simulation and Interactive Learning. And also to announce that Dr. Nadkarni and his wife, Ellen, are giving grand rounds tomorrow morning at 7:30 at the Montreal General Hospital. And there is also a special lecture tomorrow at noon here in the amphitheater on resuscitation, past, present, and future, both for pediatric and adult audience. So now we can open the floor to questions. Maybe first the outside sites. And if not, then we can open the floor to questions in the room. Questions?
This one here.
Thank you very much. Fabulous, fabulous lecture. Which children are having cardiac arrests in hospital and out of hospital? And do you think it's the same in the US and Canada?
So really good questions. I'm not sure that we really know. The information we're getting is mostly from those networks that report. So in other words, the CARES network, which covers about 23 states in the United States, has collected data in the out-of-hospital settings. And what's very interesting is that, so let's start out of hospital. For children, it's still predominantly respiratory leading to cardiac arrest when the cause is known. And and we also know that it is that the neighborhood that they live in is very important. Higher socioeconomic class, more white, gets more bystander CPR and has better survival. And even when you control for socioeconomic class, the culture that they are in, race, ethnic, etc., does make a difference in terms of the percent. Many more children, almost 60%, are receiving bystander CPR, whereas adults, it's down about 30%. They are probably a very different population from the in-hospital. So most out of hospital are under 1 year, except there's another spike in the adolescent age group, and that's more trauma and toxin, substance abuse related. In hospital, 95% of the children, at least in the U.S. and in the U.S., are arresting in the ICUs. So they're being moved with rapid response teams, et cetera, from the wards to the ICUs. In Canada, it's a bit less. It's about probably 75% in the ICUs and 25% on the wards. In adults, 60% of the arrests in hospital are occurring on the wards. Most of the children in hospital are different. They are complex care children. They have underlying conditions. Only about 10 to 20% of them are septic. And there's a much higher proportion, 5 to 1, of them having underlying cardiac conditions, plumbing issues. So there is quite a difference between the in-hospital and out-of-hospital sort of milieu. And the out-of-hospital data is oftentimes colored by the under 6-month-old who has a sudden unexplained death. And so that group, whether you count them in or out, really colors how you look at the out-of-hospital resuscitation, because many times the very young sudden unexplained death syndrome children are not resuscitatable by the time they come to medical attention. And so some people say we should probably separate those out so that we can look at the resuscitatable population. Farhan, does that match with what you know? Yeah. Ron.
Hi, Vinay. Thank you. Very, very interesting as usual. Let me challenge you on one issue that you sort of talked about, that's the issue of eCPR. We could probably talk for hours about that. So although it's not about the technology, eCPR is an extremely expensive, very high resource allocated technology with a, when it's deployed, with probably an unknown outcome. So we had this discussion in our hospital, who are really the appropriate patients that eCPR should be deployed. I wonder if you want to comment on that.
So that's a really good point. We know that in the cardiac ICU, where the lesion, the patients, the parents, and the prior neurologic function of the child is pretty well known, and the problems that are being addressed, or the cause of the arrest, is sometimes addressable with a surgical or a focused intervention that's reparable or supportable to a long-term device that would lead to a transplant, et cetera, that under those conditions, it's probably possible to both predetermine if that child is appropriate for eCPR, and also that it might be an intervention that has an endpoint. So for those children, it's quite a bit easier, and in our cardiac ICU and in many cardiac ICUs, one would pre-round, one would pre-decide, and there would be a thoughtful approach. Outside of that environment, it's much more muddy, and so we have a protocol. So I'll just tell you what we do, and you know, that's not what should be done. It's just like what's done. So for those children that we can predetermine are at high risk for cardiac arrest, we have a very similar discussion, less evidence-informed, more opinion-informed, that includes the family about whether this patient is appropriate for eCPR should the first 10 minutes of conventional CPR fail. So our protocol is really to, for those patients, we would know yes or no. The third category is those that are unexpected, et cetera. And under those conditions, we have a set of criteria: witnessed arrest, that the CPR should have been continued for less than 60 minutes by the time the patient's cannulated, right? And that they failed 10 minutes of conventional CPR, ACLS, et cetera. We activate the team at about minute 2 for those unknown ones. For that middle ground, the criteria are muddy, but at least they're discussed. And I know that at several hospitals like Dallas Children's, they actually put a sign on the child's door as to whether they are an ECPR candidate or not. So, I mean, there's more discussion going on. What do you do here, Ron?
Well, so, we had the same discussion. I was going to ask you actually about the child who comes into the emergency department for out-of-hospital cardiac arrest. Do you actually use CPR or employ it for that group? That's question one. So we agree with you that currently what we do is we offer it to the ICU patients, the ones that we know, mostly the cardiac patients, but witness arrest, similar criteria to what you have. We haven't quite extended it yet to the floors in terms, but that's also possible, and certainly not to the emergency department, not at this point.
So the only criteria in the emergency department that we'll employ is that if it was a witnessed arrest with an obvious reversible cause. So we've had some gunshot wounds in Philadelphia, gunshot wounds, that we have deployed it to the emergency department. We've deployed it for an asthmatic who was witnessed to go down. It was a known cause of arrest and it was felt to be a reversible cause, and conventional CPR was not doing the trick. And so we have restricted its use in the ED, but we have some more stringent criteria for it there. And again, it's always a controversy. One of the things I think that is helpful is that we have an immediate after-event review, and that's of the people who are in the room, and then the data is collected. And in our emergency department, we actually have video capture, live video capture of the whole event. And then we take it to a quality improvement forum, we analyze it, and we discuss it in sort of an M&M. And that's done on every case, trauma or cardiac arrest.
Hi, I just wanted to say thank you for your lecture, and I know on behalf of the emergency medicine residents, we're very happy to have been invited to this lecture, very inspiring, thank you. My question is, in terms of pediatric resuscitation in the emergency department, what are the biggest areas of improvement that we can do as emergency physicians?
So that's a really good question. So one of the things that's been really interesting is this impacts group has been sending simulation probes out to adult emergency departments and pediatric emergency departments, because adults do trauma really well. Time critical interventions are really great. But they sort of get paralyzed when a child comes in cardiac arrest, like it's different. And what we found is that the very basics, if you just don't concentrate on anything extraordinary, but the chest compression fraction in the first 5 minutes, early epinephrine in that first, getting vascular access, usually IO, and getting the epinephrine in early, and monitoring ventilation and end-tidal CO2 is probably most helpful. So trying to get that end-tidal CO2 above 20 with your chest compression, near continuous chest compressions, and not focusing on intubating the child, but rather adequately ventilating the child slowly. So when I say slowly, it's 10 times a minute. And you'll find that particularly for pediatric patients, everybody wants to breathe really fast. We don't know how important that is, but we know that it's definitely not anywhere near the guidelines. It's usually 20, 30, 40, 60 times a minute. But by monitoring the end-tidal CO2, giving some people to look at something, and concentrating on near continuous chest compressions, particularly in the emergency department where traumas, you're oftentimes trying to do a survey and there are a lot of interruptions, trying to minimize the interruptions is probably the most important thing you can do. Farhan?
Thanks, Vinay. That was a fantastic talk. I just wanted to actually ask you and put you on the spot a little tiny bit. 2 little questions. One is related to what you look at your CPR quality now. Are you, in the ICU setting, are you looking at rate depth, CPR feedback devices? Are you looking at end-tidal CO2, or are you looking at diastolic BP in light of the recent publications with Bobby and Alexis?
Great question. So we are actually looking at all 3, and it's kind of a tiered look, if you will. So in our after-event reviews, we will prioritize blood pressure if the child has an arterial line in. 60% of the cardiac arrests for in-hospital children in ICUs already have an arterial line in at the time of their arrest. And so we prioritize a diastolic blood pressure greater than 25 under 1 year of age and greater than 30 over 1 year of age as our primary determinant of was good quality CPR delivered. Absent that, if if it either wasn't captured or we didn't have one. Then we look towards a combination of depth of compression and chest compression fraction greater than 80%, and end-tidal CO2. And I'll put a caveat on end-tidal CO2. End-tidal CO2 reflects pulmonary blood flow. So if you put an end-tidal CO2 capnograph on, if you're getting blood flow to the lung, you should get end-tidal CO2, normal being 40, target being above 20 during cardiac arrest, less than 10 associated with really bad outcome. We have just looked and just published that the correlation is not so great with end-tidal CO2, and it's probably because of the breadth of underlying lung disease and dead space that there is. So it's very difficult to use that. We use it as a poor man's guidance if we don't have arterial blood pressure, but we don't rely on it as a sole quality indicator. And we have all, I'm sure you have, we have all seen cases where we've had either very good end-tidal CO2 or very poor end-tidal CO2, and it didn't correlate with return of spontaneous circulation. The important thing about diastolic blood pressure is that it's not just correlating with return of spontaneous circulation, it's actually correlating with long-term neurologic outcome. So it's probably that perfusion pressure to the brain that it's also preserving, and that's why we're really focusing on targeting. And we've started clinically putting arterial lines in during cardiac arrest, as they used to do in the 70s and 80s, because we think it may be a better guide than just the end-tidal.
And the last little tiny one, in light of our email discussion that we've been having, should I turn over my cardiac arrest and let Tanya and Samara run them, and should you hand them over to Alexis in terms of that paper and gender?
So there was a recent paper that suggested that females running codes had better outcomes for their patients than males running codes. And I just have to mention in that line also, they did some experiments. You know the AEDs, how the AEDs coach you, almost like Google Maps or whatever, Siri, etc. It turns out that paramedics respond better to women's voices that are guiding them to push harder, faster, etc., than they do to men's voices.
Hi, thank you for an interesting, very interesting talk. So I just have a question for coaching during CPR. So there's recent study that showed that human coaching, in addition to CPR device for feedback, could be beneficial. But that's assuming that you're adhering to the guidelines. And it's not because you're adhering to the guidelines that you're providing effective CPR. So with limited resources, how could you ensure both? Because ideally, you'd have like a co-pilot or a co-pilot to make sure you're adhering, and then you would have a human coach and a device to make sure that the CPR is effective. But that's not always possible.
Yeah. So I think it sort of comes back to the question from the ER guys about what do you prioritize? Like, there's so many things to be done. What's the key things that we have to concentrate on? And I would say that the CPR coach, that the coaching of CPR, not the CPR coach, but the coaching of CPR is probably one of the most important things to be done. More important than double checking the dose of epinephrine, more important than even how fast you're ventilating is probably good quality CPR. One size is not going to fit all. We can't say every place is going to have enough people to have a CPR coach and this. And so looking at your environment, your resuscitation, whether you're in an office, whether you're in the ward, and figuring out who's going to be monitoring and supporting CPR quality with whatever tools you have. We know that visual is not that great. We know that's really hard because we tried to do it with cameras and visual. It just doesn't work that well. There's just to mention, there's a recent grant that was awarded to Betsy Hunt at Johns Hopkins with this Inspire group that's going to look at a randomized time series integration of a CPR coach into these resuscitation teams before and after at each center to see if there's really an impact of a designated CPR coach on quality of care, process, and outcomes of the patient.
Very good.
That's going to be started in December and then should finish in 2 years.
Okay. Thank you.
Unfortunately, I think we'll have to stop here as it's past 9 already. But if there's more questions, you're welcome to come and speak with Dr. Nadkarni afterwards. Thank you very much.
Thank you.